My clinical case is really a real-life bedside clinical case, a true case, and it's a case of a 50-year-old man who was diagnosed with HIV cirrhosis in October 2014, that is 1 year and a half ago. His medical history was past medical history transient drug abuse, withdrawn for 20 years now, and smoking, and recently the patient was admitted for 3 subsequent episodes of hepatic encephalopathy over 2 months, grade 2 to grade 3. And on admission, the patient was stable in terms of hemodynamic, moderately overweight. We found that he had jaundice, mild edema, tensositis, and atherexis. So clearly a decompensated child C cirrhosis. Baseline lab tests show an increased total bilirubin, mainly unconjugated, varying from 3.8 to 5.2 milligrams per dl, moderately elevated transaminases, and the prontramid time quite low, 39%, corresponding to an INR of 2.2, normal renal function, and esophageal varices grade 2. Initial treatment consisted in large volume paracentesis, lactulose, cautious reintroductions of diuretics, which had been withdrawn because of encephalopathy, and propranolol, and the patient was referred in December 2015 to our institution to consider liver transplantation. An admission in our center, we found that the patient had a HIV genotype 1A, naive of treatment, mild viral load, MELD score 22, child-Pugh score C10, C11, blood type O, and we didn't evidence any contraindication to liver transplantation. This is the pre-transplant imaging, indicating moderately dysmorphic liver with perihepatic ascites, hepatopetal portal flow, and here a patent umbilical vein indicating portal hypertension. So, how to manage this patient? Obviously, TIPS was contraindicated, and the patient was listed for transplantation in January 2015, that is 15 months ago. We tried to optimize the treatment of encephalopathy by introducing rifaximin, and we went on with diuretics and paracentesis. But we have to discuss now other options, and obviously the first option we have to consider now is, should we treat this patient with DAA? Maybe I can ask the audience, who among you would treat this patient? Child C patient, MELD score 22. Who want to treat it? Please hands up. Yes, and now? Maybe. Who won't treat the patient? Okay, who doesn't know? Okay.
Was the MELD 22 really quite stable at 22, or did they have an infection and then go from a MELD of 17 to 22?
Good
or were
point.
they stable?
There was no infection. It was quite stable.
Okay.
Maybe some variation due to bilirubin, but really between 21 and 22. Okay. So, yes.
Please use the microphone.
Here, MELD 22. Probably lifelong.
The question was just for the microphone about what was the median or mean MELD in your patients who were going to go to transplant. That was a good question. Another question? Oh, okay. Same question.
So far we have probably 20% of the audience who decided to treat or not to treat, and probably 70% of the audience who doesn't know what to do. Okay, so quite concerning. Well, we think about that for a long time now at ELITA, and we have 2 successive meetings, one in 2015 and one recently in 2016 in Milano. And where we are now. So we try to take into account all the factors we discussed previously in the morning session and this afternoon session. First, avoid futile treatment, consider safety and tolerability issues, consider the probability of achieving SVR and subsequent liver function improvement, and also anticipate MELD purgatory. So we have to take into account all these factors to take our decision. And here are the 2015 ELITA recommendation. And this one deals with the issue of child C patients. And the recommendation 17 is in child QC patients with a MELD lower than 25, an improvement of either child Q score of MELD by 2 to 3 points can be achieved in 20 to 30% of the cases. However, this improvement may not be sufficient to achieve delisting, and again may limit access to transplantation. The decision whether to treat this patient or not should therefore be cautious, making sure that it will not be detrimental to the patient. So this is an elegant way to say that we don't know exactly what to do. Yeah, right. No, it's a very tricky issue.
It's good to see.
Yeah, yeah.
It's good to see.
Long recommendation, and at the end, quite nothing. So, back to our patient. How could we manage the patient? So, favoring the treatment, rather low viral load, normal renal function, no expect DDI, limited access to transplantation, and we discussed this point this morning. For patients with MELD to score 22, there is almost no access to transplantation in most of the programs, and we can expect an improvement on DAA, but the magnitude of this improvement is not well known at the moment. So against transplantation, a quite important liver impairment. I show you the bilirubin, which was quite high, the low prothrombin time. Genotype 1A may be a problem, taking into account RAF, for instance. And also, we have to anticipate on the MELD purgatory what will happen if we improve this patient, but not enough to really get it delisted. So at the end, after this brainstorming discussion, we decided to start with sofosbuvir plus the ledipasvir. And I show you now the follow-up. We achieved a very rapid early virological response, which was maintained on the long term with SVR. So we very easily achieved SVR in this patient. This is the follow-up of transaminases, which became rapidly normal. And this is the follow-up of the MELD score. And you see here that the MELD score went down progressively and quite rapidly, surprisingly. And we started from 22. By week 4, we have a MELD score of 18. By week 12, 15. And the MELD score stabilized over the next 6 months around 15, 14. And behind the MELD, what we found is that we have a rapid drop in bilirubin from 5 to 2, and which stabilized further between 2 to 3, and a progressive rise in prothrombin time, which stabilized around 60%. In terms of child Q score, what happened is that we had a very parallel evolution to the MELD score. Here the figures in red are the MELD score, here the child, and we start with the child Q score at 11, and then week 4, 10, week 12, 8, 8, and then even A6 here on week 36. This means that actually this patient was free of ascites, and the last paracentesis was performed on week 12. The patient was no more encephalopathic at that time, and we decided to put him in inactive position on the wait list, because really the risk-benefit ratio for liver transplantation was no more favorable. No more ascites, no more encephalopathy, MELD score 15, and we went on like that. We even stopped furosemide later on. Unfortunately, what happened there is that on week 38, again, the patient was admitted for an episode of hepatic encephalopathy, grade 3. So very important severe episode of encephalopathy. So what to do there? And this is the evolution of the position of the patients on the national waiting list. You have to keep in mind that in France, we have a nationwide allocation system with no local priority. So, and we have also the possibility to very strictly follow the position of our patient on the wait list, thanks to a program which name is Crystal, ensuring transparency, total transparency. And you see that when the patient's group type blood O was listed, he was in position 50, and then rapidly following the improvement in MELD score, he went down to rank 134, then 161, 174, etc. And here, when the episode of encephalopathy occurred, the late episode, he was really very, very far on the wait list with absolutely no access to transplantation. So what to do? Well, as in every program, we have the option of the MELD exception, and we ask to our OZO MELD exception, and we've got them. And in the French system, when you get the MELD exceptions, the patient goes down at the bottom of the list, so he ranked rapidly after obtaining the MELD exception to 286, and then gained points on a weekly basis up to 65 here. So this is how we manage the patient. So in summary, 5 questions are raised by this clinical case to take into account in the decision to treat or not. What's the chance of getting SVR in advanced decompensated cirrhotics? And this was discussed in depth by the previous speakers. Is there a chance of being inactivated and further delisted during the waiting phase after DAA therapy? Impact of the MELD purgatory and risk of death or chance to be transplanted, as discussed this morning. Are there any reliable predictors of MELD improvement, inactivation or delisting? And how long may last improvement after DAA therapy? So in the next slide, I will briefly show you how we manage these issues at ELITA. And for discussing all these questions, we set up a second meeting dedicated to the issue of management HCV and HBV in Milan 2 weeks ago. And we extensively discussed this European study, which was presented and led by Luca Belli, and these results will be presented at the ILC meeting this week. And basically, we retrospectively review the charts of 100 patients who had been treated with DAA among 11 European centers over the last 2 years. Here are the features of the patients. Half of them had the MELD score higher than 16, half of them lower than 16. In terms of virological efficacy, half of the patients were treated only with soft plus riba, and we had 4 relapses among these patients. But for patients who were treated with dual therapy, we have no relapser while on the wait list. So clearly, great virological efficacy. And if we focus now on the most severe decompensated patients, we had 19 patients listed with MELD higher than 20, and we achieve HBV RNA clearance on week 12 in 89% of the cases. And as discussed recently, among the non-responders, we had 1 patient who died of sepsis and 1 patient in whom we had to withdraw the treatment because of pancreatitis. For the other patients, 3 patients, 15%, including really severe patients, were inactivated for clinical improvement. And here are the figures and the probabilities of being inactivated among these 100 patients or delisted. And you see here that after 1 year of treatment, we had 33% of the patients who were inactivated with sufficient improvement to really getting free of clinical manifestation symptoms, and almost 20% of the patients were actually delisted. So really, in one-fifth of the patients, we can achieve delisting in these patients. And then we move to try to define some predictors of inactivation. And by using competitive risk analysis and a multivariable model, a quite sophisticated model here, we identified 3 predictors of inactivation. MELD at baseline. The higher the MELD, the lower the probability to be inactivated, but also 2 dynamic factors. Delta MELD, this is the difference between the MELD at baseline and the MELD at 12 weeks after treatment, and also delta albumin. So the higher the delta MELD, the improvement of the MELD, the higher the probability to be inactivated, and the higher the improvement in the serum albumin, the higher the probability to be delisted. And we combine these 3 factors all together, and we define here different scenarios. The best scenario, suppose for instance the patients with MELD at listing lower than 16 and a huge delta MELD, for instance, a MELD who goes from 16 to 12, delta MELD is 4, and also significant improvement in albumin. You have here an almost 80% chance to be delisted when you have this combination of 3 factors. If you focus now on our patient, MELD higher than 20, delta MELD higher than 4. You remember that the patient had 22 and we arrived at 14. So an improvement in delta albumin, you are here. This means that actually you can achieve delisting in these patients even is the not that high MELD score in 20% of the cases. And by combining these three variables, you can really get an interesting prediction of what may happen. So, just to conclude, I suggest you, this is just a suggestion, three different scenarios. Anyway, decision to treat or not a decompensated child cirrhotic waiting for transplantation is a difficult one and should be considered on a multidisciplinary approach. For patients with high MELD, higher than 25 at that time, I don't know if it's the right cutoff, we suggest that for safety and utility issues, clearly this patient should benefit of treatment post-transplant. For patients with medium MELD score, which was the situation of our patient, we suggest to discuss the option on a case-by-case basis, taking into account how easy the patient is to be treated. For instance, how easy can we use ribavirin or not, and to start with treatment in the case of the patient is considered as easy to manage. And we analyzed and we assessed on week 12 the dynamic predictors together with the baseline MELD score. And for patients with low probability of further improvement, we keep them in active position and proceed with transplantation. For those with modest MELD improvement that may have a clearly purgatory effect, we suggest to maintain and to keep them in active position with baseline MELD value. This means that if we want to counteract the purgatory effect, we should ask and negotiate with our authors to keep the baseline value, MELD score value. For instance, this is a proposal. And for those who have a reasonable probability of delisting, wait and see, allocation according to MELD, and we'll consider inactivation and further delisting depending on the subsequent evolution of the lab test and the MELD score. And the question is when not to treat, which MELD cutoff to choose. We don't know exactly. We discussed that extensively 2 weeks ago at ELITA and during the consensus meeting. The expert opinions in the panelists suggest MELD 20. Maybe, as I show you based on this clinical case, 22 would be an option because we have a 20% chance to get an improvement in those patients, provided the MELD score improves sufficiently. So somewhere around that, 20, 21, 22. We'll discuss that. But you know, we refine progressively the cutoff. And for the easiest patients, low MELD score between 15 and 20, quite easy. We start with DAA. And we analyze the predictors of further improvement on week 12. If there is clearly an improvement with a reasonable option and probability, inactivation and delisting. If the patients further deteriorate, we have the option to consider MELD exception points. These are my suggestions. I thank you for your attention.